Hi, I'm Samir Lodha. I'm one of the orthopedic hand surgeons at Panorama Orthopedics. I'm just going to be talking to you a little bit today about ulnar nerve entrapment neuropathy, or cubital tunnel syndrome. Generally speaking, ulnar entrapment neuropathy is caused by a compression of the nerve at the level of the elbow, and that compression happens just behind that bump on the inside part of your elbow. It's often what's referred to as the funny bone, and that's where you'll get that sort of sharp tingling sensation if you bump that area. That's because of the ulnar nerve. In some patients, there's a band of tissue there that can become tight around the nerve and can compress the nerve in very similar fashion to what happens to the median nerve in the carpal tunnel, and can cause symptoms that are felt mostly in the hand. So the main symptoms that people can complain about when they have cubital tunnel syndrome or ulnar entrapment neuropathy is numbness, primarily in the small finger and in the ring finger of the hand. If the neuropathy gets bad enough or has gone on for long enough, it can actually start causing weakness in the hand, specifically in grip, and can ultimately end up in wasting of the muscles of the hand, and you can actually see that as hollows that develop between the various bones in the hand. So the diagnosis of ulnar entrapment neuropathy or cubital tunnel syndrome is primarily clinical, and you can tell that from both the constellation of symptoms the patient has in terms of where their numbness is in their hands, as well as from certain provocative physical exam maneuvers. If I tap on your elbow right in the area of the funny bone, people with ulnar entrapment neuropathy or cubital tunnel syndrome will have tingling in those last two fingers, the small finger and the ring finger often. The ultimate diagnostic maneuver that we use is obtaining electrodiagnostic studies, which some of our PM&R partners perform, where we actually pass current through the various nerves and use that to identify areas of the nerve that are having some form of compression or other pathology. The initiation of treatment is almost always non-surgical. It begins with an appropriate diagnosis, and then we identify the kinds of activities that the patient does that are provocative for their symptoms. So, for instance, some people tend to read in very awkward sort of positions, which often spur their symptoms. Other people rest their elbows all the time on hard surfaces, which can often cause symptoms of ulnar entrapment neuropathy. So we'll go through that and identify those provocative type of behaviors that people have and try to adjust those. An ergonomic evaluation of a person's workspace can also help in identifying some of the problems that cause these symptoms. If people are having symptoms at night that are waking them up from sleep, what we'll often recommend as a first step is wearing an elbow pad with the pad part in the front, which prevents people from bending their elbow at night, as that puts more tension on the nerve. So by preventing that tension, we can often alleviate a lot of the symptoms. Additional treatment options can include therapy, including what's called nerve gliding type exercises, which can reduce some of the scarring around the nerve and can improve symptoms in some cases, as well as potentially anti-inflammatories or some nerve sensitivity medications, including medications like gabapentin or Lyrica. There are two main situations when we consider operative intervention for ulnar entrapment neuropathy. One is if non-operative measures fail to relieve symptoms, and the other is if electrodiagnostic studies or the physical exam findings indicate fairly severe disease or a chronic condition where there's actually damage that's being done to the nerve. In those cases, surgery involves releasing the nerve or releasing any of the compression bands around the nerve, both at the level of the elbow and, if needed, at the level of the wrist. Surgery tends to be very successful in relieving these symptoms, but as is generally the case with nerve-associated surgery, the earlier that we identify those symptoms and the problem, and the earlier we intervene, the better the results.